All right. Good afternoon, ladies and gentlemen, and thanks for joining us for atrial fibrillation 101. I hope everybody can see the slides. You have video, everybody can hear me. Great. Let us know if you can't hear. Just a couple of housekeeping items. I'm going to go through some of the information I want to cover today. Meanwhile, please use the question and answer widget to put your questions to our moderators. Moderators will continuously look through the questions while we're chatting. And then uh, towards the end of the presentation, I will be able to answer them. So without further ado, I see a lot of familiar names on the list of attendees. It's great to see all of you there. For those of you who don't know me, my name is Dr. Yaariv Khaykin. I'm a cardiologist and an electrophysiologist or a cardiac electrician, looking after a number of patients with various cardiac conditions, but none are more common in my practice than atrial fibrillation. And today, I wanted to cover this topic dear to my heart. This is February is a heart month, and this February happens to be 20 years since we've done our first ablations for atrial fibrillation at South Lake Regional Health Center. Please use the QR code on the screen to access some of the resources we've put together for our patients suffering from atrial fibrillation. All right, so today I will cover what atrial fibrillation is, how we go about diagnosing atrial fibrillation, what treatment options are available, and we'll talk about lifestyle modification, medications, cardioversion, ablation, and left atrial appendigeal occlusion, relatively newer procedures that we're able to offer our patients. We'll also talk about how you can manage your symptoms and reduce your risk, stroke prevention, lifestyle management, and controlling various triggers for atrial fibrillation. Those of you who've seen me as patients know that we usually talk about it before we even get into medications and ablation. Atrial fibrillation is the most common abnormal heart rhythm or arrhythmia. It affects 0.5% of the world's population, which includes more than 6 million Americans and more than 500,000 Canadians. 1/4 of those of us who are over 45 will have atrial fibrillation at some point. Unfortunately, patients with atrial fibrillation are 3 to 5 times more likely to suffer a stroke, and about 1/4 of all strokes that happen after the age of 40 are attributable to atrial fibrillation. I wanted to tell you a little bit about anatomy and how that plays into atrial fibrillation. So let me get my pointer and make sure you can see it. So this is a schematic showing your heart. This is the right upper chamber of the heart, or the right atrium, and the left atrium with the pulmonary veins at the back of the chamber over here. You see the valves between the left upper and left lower chambers and between the right upper and right lower chambers. Down here is an opening to the vein that brings blood from your lower body, from your leg. And for those of you who've had procedures in the lab, this is where the catheters come into the heart typically. This is the vein that brings blood from the neck. Now, we're all born with a natural pacemaker in our heart called the sinus node. Sinus node is specialized tissue that sits at the top of the right upper chamber of the heart, and it's responsible for generating our rhythm. Typically, sinus node generates about 60 beats per minute. It can go slower if you're sleeping and don't need as many beats per minute, or faster when you're running after a bus or away from a tiger. Now, heart consists of muscle, some framework that sort of gives muscle and other tissue space, and the conduction tissue. And so there's dedicated conduction tissue in the upper chambers that makes sure that the upper chambers activate over a relatively short period of time, pumping blood from the upper chambers down to the lower chambers. And conduction tissue right here called the AV node. This is a system of wiring that conducts electricity from upper chambers down to the bottom chambers of the heart. The AV node is linked to the His bundle that then splits into bundle branches that travel to the left and right lower chambers. Electrical wiring in the heart conducts electricity about 10 times faster than the muscle itself, and so the heart activates rapidly, and in normal rhythm, it activates regularly. This shows an ECG, and you can see, waveforms, which we call, the little one over here, we call the P wave, and the big one over there, we call the QRS complex, and then the T wave. The P wave signifies activation of the upper chambers. This big one over here, QRS complex, activation of the lower chambers, and then the T wave tells us about the lower chambers, or the heart sort of recharging and getting ready for another beat. What happens in atrial fibrillation? Well, let's have a look. So in atrial fibrillation, instead of having an organized heart rhythm going at a steady rate, as I said, around 60 give or take beats per minute, there's an electrical storm in the upper chambers where little short circuits and discharges go on at around 300, 400 or more beats per minute. How do you develop atrial fibrillation? Well, in most patients, atrial fibrillation is started by extra beats, extra electrical impulses that get fired out from the veins that drain blood from the lungs into the left upper chamber of the heart. I tell patients that these extra beats or discharges are sort of like somebody's throwing matches towards a can of gasoline. If one of those beats happens at the wrong place and time, it triggers this electrical storm. Now, our muscle, the muscle in the upper chamber of the heart, is not meant to go at such a rapid rate. And so when the upper chambers start electrically activating at 300 plus beats per minute, the muscle just poops out and stops pumping altogether. When that happens, first of all, you may lose some of the heart function. Anywhere from about 7 to 30% roughly of the heart muscle function is contributed to by the upper chambers, depending on the patient. As they stop pumping, they essentially become collecting chambers. Blood still flows through them, but they don't pump and contribute to kind of loading the gun, loading the lower chambers of the heart to pump the blood around your body and into your lungs. Moreover, there is a little cul-de-sac in the left upper chamber called the left atrial appendage, and blood clots can form in the left atrial appendage. These blood clots can then go places and give you a heart attack, a stroke, a blood clot to the kidney, your leg, your arm. You can imagine it's not pretty. The second thing that happens is, as the upper chambers go really fast, a lot of these impulses get conducted through the conduction system to the bottom chambers, and the bottom chambers start going really fast and irregular. And when they do, over a long time, go so rapidly and irregularly, patients develop what we call tachycardia, or rapid heartbeat, mediated cardiomyopathy, or abnormal heart function. So essentially, the function of the lower chambers of the heart deteriorates if they're driven at a rapid, irregular rate for extended periods of time. You can see that the electrical recording of the heart activity is also quite abnormal. You no longer see these nice little P waves. You see kind of a relatively flatter and somewhat irregular baseline, and the QRS complexes signifying activation of the bottom chambers of the heart happen sort of all over the place at an irregular and rapid rate. We classify atrial fibrillation into paroxysmal episodes that happen kind of sporadically and last anywhere from about 30 seconds to less than 7 days. You need to have 30 seconds of arrhythmia for it to be called atrial fibrillation. In other words, the mechanism of a shorter episode of arrhythmia may be the same, but it doesn't meet the definition. So somebody may say, well, I have a little flutter, lasting for 5 seconds. Well, 5 seconds would not be enough for us to call it atrial fibrillation per se. Paroxysmal atrial fibrillation episodes typically stop on their own without us having to help the arrhythmia along with shocks or medications. Persistent atrial fibrillation episodes last for 7 days or longer, but less than a year, and typically need help for the patient to get back to normal rhythm. And we'll talk about what that may entail later in the talk today. And then long-standing persistent atrial fibrillation is arrhythmia that goes on uninterrupted for longer than a year. There's obviously permanent. Permanent is arrhythmia, and where you sort of have given up on trying to get somebody back into normal rhythm, or you've tried to get them back into normal rhythm and really couldn't. And so a decision is made to leave the patient in atrial fibrillation indefinitely. Why do you have atrial fibrillation? Well, we don't know for sure, but we do know that a lot of the arrhythmia has to do with either scar formation in the upper chambers of the heart or abnormal milieu, abnormal electrolytes, abnormal factors, hydration, etc., that may make you more likely to develop this arrhythmia. So atrial fibrillation is extremely uncommon under the age of 50. Less than 1% of episodes of atrial fibrillation happen in patients who are younger. Our practice is so large, and we've seen so many patients over the years that we've certainly seen patients who are younger. And I think the youngest patient I've seen with atrial fibrillation was a 16-year-old, but it's very unlikely. 6% of patients at age 65 have atrial fibrillation, and 28% of the population over 80 have atrial fibrillation at some point in time. Most common risk factors or lifestyle factors that associate with atrial fibrillation are listed here. One of the more common ones is alcohol. And alcohol can be associated with atrial fibrillation in several ways. It can be a direct trigger, and frequently we see what we call the holiday heart syndrome, when somebody comes into the hospital on Monday after having a bit too much to drink over the weekend. In some people, even a single beverage, even a single glass of wine can trigger an episode of atrial fibrillation. But in others, it's not so much the specific event where they had a glass of wine or they went to a party over the weekend. In some people, it's just a regular habitual intake of alcohol and caffeine, which may lead to underhydration over time, and over time increase the risk of going out of rhythm. Both alcohol and caffeine have direct effects on the autonomic nervous system, which may help precipitate an episode. And both are diuretics, essentially making you go to the bathroom and lose some fluid. Lack of proper hydration. A lot of people, that I meet in the office don't drink enough fluids on a good day. A lot of people would typically be drinking maybe 1 or 2 glasses of water per day, and they might down those with about 5 glasses or 5 cups of coffee, 1 or 2 alcoholic beverages a day, etc. And that's a very dangerous behavior. We sort of tolerate it relatively better when we're younger. As patients get older, I see patients coming in with arrhythmia, fainting spells, dizziness, fatigue, and all sorts of other problems that at their core have excessive intake of alcohol or caffeine for that particular patient with inadequate intake of fluids. We typically talk about 2 liters of water without intake of alcohol and caffeine as a bit of a gold standard for most patients, obviously with some exceptions. Obesity is an important risk factor for atrial fibrillation. Obesity is the root cause for a number of problems we face in patients with cardiac problems, such as diabetes, high blood pressure, high cholesterol, and atrial fibrillation. There are studies, both animal and human studies, that clearly show association between obesity and arrhythmia. There are also studies that show that weight gain increases the likelihood of having an episode of arrhythmia, and weight loss leads to a diminution in the number of episodes somebody may be having. Obesity also contributes to the risk of someone developing sleep apnea. Sleep apnea is a condition that if you're married, your spouse is aware of. That's a condition when you can stop breathing in the middle of the night when you go into deeper sleep. There are about 4 stages of sleep plus rapid eye movement sleep. And when we go into the deeper stages of sleep, and some people, the throat closes, they try to take a breath against a closed throat, their oxygen levels plummet, and the body starts making hormones such as adrenaline, noradrenaline, etc. Blood pressure goes up with the idea that they would wake up or at least go from deeper sleep to lighter sleep. Sleep apnea is related to obesity in at least some patients, and sleep apnea can also be a trigger for atrial fibrillation and has been associated with stroke. Magnesium deficiency is also common in our patients, particularly in those who take regular diuretics, such as chlorthalidone or hydrochlorothiazide and dopamide and others for their blood pressure. Many of the diuretics act by getting you to lose some of your salts with water kind of following the salt. And in the process, you tend to lose potassium and magnesium. Those levels go down. And when your potassium and magnesium levels decline, your cells become kind of jumpier and more likely to go out of rhythm. And finally, this is an unusual category for me to talk about, is endurance athletes. So those of us who work really hard, these are marathon runners, those who compete in Ironman, professional athletes, really stress out their heart. For most of us, when we go about our activities, our heart pumps about 5 liters of blood every minute, as the heart pumps. But when somebody is actively exercising, that may go up to 15 or 18 liters per minute. That blood got to go somewhere. And what happens is the upper chambers of the heart really stretch to accumulate or accommodate that increased return of blood. And we think that over time, that stretch may lead to some scar formation in the upper chambers that then become a trigger for atrial fibrillation. Certainly a number of my patients have come from that group. Medical conditions associated with atrial fibrillation include congestive heart failure and cardiomyopathy or dysfunction, malfunction of the heart chambers, valve disease, particular disease affecting the aortic and in particular the mitral valve of the heart, the valve between left upper and left lower chambers, diabetes, high blood pressure, thyroid disease, as well as certain genetics may predispose you to having the arrhythmia. Patients who come to us suffering from atrial fibrillation complain of a variety of various symptoms. It's really difficult to say, well, this symptom says that you're having atrial fibrillation. That does not exist. Symptoms and the way you perceive the arrhythmia are quite different for patients. We have some patients who have no symptoms whatsoever. In others, symptoms may range from feeling anxious, shaky, sweaty, dizzy, lightheaded, rarely losing consciousness, to just feeling tired, unwell, out of sorts. And then in between, there's all the others, such as patients feeling irregular heartbeat, palpitations, fluttering in the chest tightness or heaviness, and activity intolerance. Typically, we find that younger patients come in, they feel palpitations, they feel some of the symptoms of anxiety, and a number of patients who come in with atrial fibrillation and other arrhythmias may have been diagnosed with anxiety for years before somebody discovers that, in fact, they're having an arrhythmia. So it's very important in those patients to check and make sure that their symptoms of anxiety do not, in fact, represent an arrhythmia as opposed to purely anxiety as such. And certainly there's a lot of interplay between the two conditions. Among the older patients, we more commonly see patients just feeling tired, out of sorts, out of breath, not able to do what they like to do, many of them attributing it to their age until we discover that, in fact, they're having atrial fibrillation. And in many of those patients, when we stop the arrhythmia and try to prevent it, they feel a lot better and their energy levels improve dramatically. Atrial fibrillation is not a walk in the park. It's certainly a nuisance, and in younger patients, the main issue we worry about is their symptoms, but it can lead to significant problems. We already mentioned blood clots forming in the left atrial appendage causing stroke, development of malfunction of the heart called cardiomyopathy because of rapid heart rates, and in some of those patients actually developing full-blown congestive heart failure. To give you an extreme example, I had one of the patients I've had with atrial fibrillation would have a completely normal heart when they were in normal rhythm. And when we say, somebody's heart is normal, abnormal, we use a ballpark of the pumping chamber of the heart, pumping about 60% of blood in it every time it pumps. Well, in that patient, it was perfectly normal whenever he was in normal rhythm. But when he would go into atrial fibrillation, the heart muscle function declined to where the left lower chamber of the heart would only pump kind of single digits, 8 or 9% of blood in it every time it pumped, and the patient had to go to intensive care unit. And I know there are others of you who have had similar experiences. This is just an illustration, again, showing a blood clot in the left atrial appendage, which is responsible for 90% of stroke-causing blood clots that relate to this arrhythmia. And this is an illustration of what I mean when I talk about cardiomyopathy. So the illustration on the left shows a normal heart, where you can see normal heart muscle of the left and right lower chambers of the heart. On the other side, you can see a cardiomyopathic heart. Now, we hope this doesn't happen. So most of the time, when you just go out of rhythm and your heart goes rapidly, even though the function deteriorates, structurally the heart stays relatively normal. And so we can let the heart muscle recover by getting you back into normal rhythm. But if left long enough, something like this may happen, where the actual substrate, the actual muscle deteriorates over time. How do we diagnose atrial fibrillation? So as I mentioned, there's no single symptom that tells us that that's what you're having. And so we typically use an electrocardiogram or ECG to document the arrhythmia. Now, ECG used to come in only a single form. Some of you may remember you would go to the doctor and the doctor would attach these metallic suction cups with little bulbs to your skin to get the recording across multiple leads. Over time, the little suction cups became stickers, and then what we call dots, little ECG electrodes with gel on the one side and the little button on the other that connect to cables. The cables connect to a computer, and that allows us to get an electrical recording of the heart. The electrical recording we typically get at the office using a machine. I'm going to skip around just a touch. Using a machine such as this allows us to record multiple leads or multiple vectors, multiple ways of looking at the heart. Each one of those ECG lines or ECG vectors is sort of like looking at the electrical activity of the heart from a different perspective with a different camera. It's sort of like the heart having an electrical photo shoot, so to speak. And it's nice to be able to see it from multiple perspectives to kind of look at the various nuances of this condition. Now, over the last few years, a number of wearable consumer devices came about that allow you to record your ECG, typically just a single lead ECG at home. The more common ones include Apple Watches as one example. We'll talk a little bit about Holter monitors, monitors that allow us to record the heartbeat over hours or days, implantable monitors that allow us to record it over the years. We can also look at the heart rhythm where if you have a device for another reason, such as a pacemaker or implantable defibrillator. And then whenever we talk to a patient with atrial fibrillation, we also want to look at their blood work, make sure their electrolytes are okay, and an echocardiogram to examine the structure of the heart and make sure that there are no significant problems affecting heart muscle function, that the valves are not too narrow or leaky, that the upper chambers are not particularly enlarged, that the pressure in the lungs is not overly high, all factors that may contribute further to the arrhythmia. So this just shows you a comparison. Again, this is kind of your classic ECG machine that you can, that we've used in the hospital or the office, where you get multiple lines. Each one of the lines is sort of like an electrical photograph, so to speak, of the heart taken from a different perspective. Common devices out there include cardiomobile devices. It's a little card with a couple of metallic contacts. You put your fingers on it, and again, it records a single ECG lead. Apple Watch or Samsung Watch does it by contacting your wrist underneath the watch and then having you touch your finger to the crown on the watch, completing the circuit, and again, allowing you to record a single ECG. Holter monitors come in various varieties. This is kind of the more common one that we've seen over the years, where a monitor is sort of like a Walkman, for those of you who remember what that is, that you carry around. It's connected by wires to electrodes on your skin, allowing us to record your heartbeat into the memory on the Holter over a period of hours to days, typically up to 14 days in many of our patients. While it provides very useful data, most of our patients are not particularly keen on wearing these monitors for prolonged periods of time because of the hassle. It's cumbersome, it's uncomfortable, and the electrodes, the little gel glue on the back of the electrode, while providing really good electrical signal, tends to irritate the skin. Many patients, break out in rashes and come back with a diagnosis, but unhappy from the entire experience. Some of the newer devices have these patch Holters. Patch Holters essentially are a combination of a USB stick with a couple of electrodes, all combined into sort of a Band-Aid-like device. You wear this device, it typically records just a single lead ECG. You throw it in the envelope and ship it to your doctor or the company that does the processing, and they process the recording. Again, because it's a Band-Aid, because it's got glue, it may lead to skin reactions. You can't take it off in the middle of a session, and most people are not particularly keen on wearing these for prolonged periods of time. We do have the option of implantable monitors. Implantable monitors sort of also look like little USB sticks. They have electrodes at either end of the device with a battery and a computer inside. It records the ECG continuously, but it doesn't keep all of that information. It sort of records and erases typically about a 2-minute window. And if certain conditions are met, like it detects that your heart went too fast, too slow, had an irregular pattern, or if you activated it with a remote control, it would remember that 2-minute window until the memory banks are cleared. So it does not allow us to see a continuous recording of everything that's happened. And it is an injectable or implantable device. And so it is invasive, but it does allow us to monitor your heart over a period of years. Now, we've been working with a partner in Toronto. It's a Toronto-based company. And some of you who've been through the clinic recently may have seen these devices. This device is akin to a Holter monitor, except it uses no wires, no stickers, no glue, no skin reaction, no irritation, inflammation, etc. These devices are called Skin as a family, and they're made by a company called Myant. The devices are packaged into either a little band that you wear around your chest, or for women, they come in several different varieties of a bra. All of these devices have garment electrodes, essentially fabric electrodes, that are part of the band at the bottom of the bra here, or on a dedicated band device itself. There is a little sort of computer transmitter that gets inserted into the pocket on the outside of the device. And this is responsible for actually recording signals and transmitting those signals to an application on your phone. And then your phone transmits the data over wireless or cellular to the cloud, and we're able to see the ECG on our end on a dedicated clinician portal and analyze the data the same way we would analyze a Holter. In addition to an ECG, so first of all, it transmits a 3-lead ECG, so we get 3 rather than just a single ECG line like we would with most patch Holters, Apple Watches, Samsung Watches, or LifeCore cardio devices. It also allows us to collect further insights into your health by sending us information on your heart rate, respiratory rate, heart rate variability that tells us more about the state of your autonomic nervous system. It tells us about your activity, how active you are, how many steps you're doing in a day, your motion, your location, whether you're sitting, whether you're standing, whether you're laying down. It gives us some data related to your sleep, as well as monitoring core body temperature, which was particularly important during the pandemic. So during COVID, we could see if somebody's temperature went up sometimes before the patient would. You then use the app provided with the device to document your symptoms. And a clinician like myself can look at a portal on my end and see what your heart rhythm and your ECG was like when you were experiencing those symptoms. There is a future version of the device coming soon that will add better sleep tracking as well as non-invasive blood pressure monitoring, oxygen saturation monitoring, slip and fall detection to the functionality of the device. Kind of, just like Beyond Meat, this would be sort of more of a Beyond Holter, and something that's currently available, and we've been using it both to monitor patient symptoms as well as a replacement for Holter monitors in our patients. This is what I see on my end when you record one of your symptomatic episodes. I see, this is just one lead of the ECG, but I actually see, if I showed you the entire screen, I see all three. I can go back and forth. It's a continuous recording. It's not just a 2-minute window. We see, 3 months back and forth of your ECG. And I can also see what you were doing when you had those symptoms and when you reported them, what your heart rate was like, what you were doing, how many steps you did that day, what your body temperature was like, etc. The system also allows us to see what these parameters do over time and trend your biometrics. And that may be important, some of the time, for instance, as you're getting sick, your temperature may be going up, your heart rate may be going up, but at the same time, your activity levels may be going down. So the device, if you're wearing it continuously, allows us to see what happens to your biometrics over time and help us monitor your health and intervene potentially before you're aware that you're having a problem. Now, stepping back a little bit, we'll talk a bit more about why we treat atrial fibrillation and what the pillars of treatment of atrial fibrillation are. And these typically include reducing your risk of stroke, improving the quality of life, and reducing the risk of developing heart failure and cardiomyopathy. We'll do this through the lifestyle interventions we already discussed. We will talk a little bit about medications for stroke prevention, control of your heart rate, control of the rhythm, making sure that you stay in rhythm rather than persistent atrial fibrillation. We'll talk a little bit about a cardioversion, a procedure we use to get you back into normal rhythm, ablation, and left atrial appendage occlusion to prevent stroke. As many of you know, every time I chat with my patients, I always talk about lifestyle modification. We always talk about weight and sleep and hydration, alcohol and caffeine. To help you even further, we helped create a wellness service called MyView. MyView is staffed by dedicated health coaches, exercise and nutrition specialists, psychologists that could meet with you virtually on a weekly basis and provide you with lots and lots of information to help you stay on track with your lifestyle modification as you go through your journey. And typically the focus is, as I already said, on reduction and avoidance of alcohol and caffeine, hydration, maintaining of healthy weight, sleep hygiene, mindfulness, and magnesium supplementation, if appropriate, depending on the patient. This is our team. Leslie, who's been corresponding with you while I've been chatting, is right here. We have Alexa, Anna, Julia, and Mason, who are all ready to help you online using the MyView portal. When you're on the program, you get access to a portal, and the portal gives you access to your care plans, to a lot of curated information, especially for you. It allows you to track your health in a number of different ways, connecting wearables, if you have them, to the tracker and communicating with your coaches over time. Switching gears a little bit, we'll talk a bit about stroke prevention. So for those of you who don't know what stroke is, there are a couple of different kinds. One is a stroke caused by a blood clot that goes into a blood vessel. It plugs up the blood vessel. The cells where that blood vessel is flowing stop getting oxygen and nutrients, and over a relatively short period of time, they die. So the neurons, the brain cells, brain tissue dies, becomes edematous, becomes swollen, and part of your brain malfunctions. With that, patients may present with problems with their speech, loss of consciousness, droop on one of the other sides of their face, weakness or numbness involving the arms, legs, etc. In the case of atrial fibrillation, we're most concerned with blood clots forming in the heart that can then travel up to the brain and lodge in one of the blood vessels or many blood vessels. Frequently, these are relatively large blood clots, and a lot of the time they may break up on the way up to the brain, affecting multiple areas of the brain, not just a single area. Another form of stroke that I do want to mention is bleeding in the brain. So bleeding in the brain is called hemorrhagic stroke, and it certainly is a real problem. And it is a real problem in some patients with atrial fibrillation. But really the main issue that we're concerned about is stroke related to blood clots in our patients. Whenever we evaluate one of our patients, we always look at the factors that may predispose them to having a stroke, make them more likely to have a stroke. There's a number of studies looking at the various factors, but generally speaking, we'll look at CHADS or CHADS-VASc criteria, which include history of congestive heart failure, high blood pressure, age greater than 65 or 75, depending on the scale, history of diabetes, previous blood clot, stroke, or TIA is a transient ischemic attack or kind of a stroke that didn't last very long. Now, women have a slightly higher risk of stroke than men, and people with vascular disease, that's blockages or narrowings in blood vessels elsewhere in their body, such as coronary blood vessels to their legs, etc. People with an aneurysm in their aorta, they're more likely to have a stroke related to atrial fibrillation than other patients, all other factors being the same. In Canada, these are sort of American and European versions. In Canada, we always try to be different. And so we try to combine the two into a score called CHAD65, whereas the original CHAD score age cutoff is 75, and in CHADS-VASc it's 65. We decided to go both ways, and essentially we would typically recommend that our atrial fibrillation patients who are over 65 need to be on OAC or oral anticoagulation therapy or blood thinners, as well as those with prior stroke or blood clot, those with history of high blood pressure, heart failure, diabetes, vascular disease, etc. We need to develop a patient-specific strategy to help prevent or reduce the risk of stroke. Medications we typically use for that purpose include the following, dabigatran or Pradaxa, rivaroxaban or Xarelto, apixaban or Eliquis, edoxaban or Lixiana, and warfarin and Coumadin. As you know, each medicine has kind of what we call a generic name and a brand name, and so both are listed. Now, many of you who've had atrial fibrillation, I'd say before 2010, give or take, would have been on warfarin. Warfarin is the rat poison medicine. It works well, but it's cumbersome to use. If you were to take antibiotics for a cold or flu, typically, you would need to take less warfarin. If you're on amiodarone, a common medicine we use for treating atrial fibrillation, you would need to be on less warfarin. If you had a green salad, you would need more warfarin, etc. So people on warfarin need to check their blood levels for a test called INR on a relatively regular basis to make sure that their blood is not too thin and they're at risk of bleeding, or too thick and they're at risk for stroke. And there are some patients, like patients with mechanical valves, that still have to be on warfarin this day. Now, for most of the rest of our patients, they're able to switch, and most of you out there, if you have had atrial fibrillation more recently and don't have very specific risk factors, would be taking what we call direct oral anticoagulants, or the more kind of newer or novel medications, which are the first four on that list. Now, we can kind of go through some of the nuances that make these medications different from each other, but really these medications are more similar than different. And aside from very special cases, both the safety and the efficacy of those medications is very similar in most patients. Once we've decided whether or not you need to be treated with medication in order to prevent stroke, we then look at, well, are you spending a lot of time in atrial fibrillation, and is your atrial fibrillation rapid? And if it is, you may need to be on what we call rate control medications. These include beta blockers, calcium channel blockers like diltiazem, as well as an older medicine called digoxin. We also want to look and see, well, how do you feel? You may be in atrial fibrillation, but your rate is perfectly well controlled. You don't have any symptoms. Your exercise tolerance is excellent. Maybe rate control is really all that you need. On the other hand, most of the patients that come to us because they're not feeling well. Are you having any of those symptoms we talked about before? If you're not feeling well because of atrial fibrillation, then you may need a rhythm control medication. Rhythm control medications are used to help you stay in rhythm or help get you into rhythm if you're in atrial fibrillation. These medications are quite different amongst themselves with very special kind of contraindications and risk profile for these medications. But generally, all of the medication on this page make you feel tired. And sometimes the medication makes you feel more tired than the arrhythmia itself. There are a number of patients who cannot take specific medications. So, for instance, if you have kidney problems, you cannot take sotalol. If you have abnormal heart function or history of a heart attack or coronary disease, you cannot take flecainide. If you've had trouble with your lungs or liver, you cannot take amiodarone, etc. Whenever you can take these medications, most of these are only effective about 30% of the time. Amiodarone is the most effective, but even amiodarone is only effective about 50 or 60% of the time, and it has a number of long-term side effects, and the longer you're exposed to amiodarone, the greater is your risk. And that leads me to the advent of AF ablation. This is a schematic of the left upper chamber, right upper chamber. Very important studies in late 90s showed that for most patients with atrial fibrillation, the arrhythmia is started by extra beats that come out of the pulmonary veins, the veins that drain blood from the lungs into the heart. What that looks like to an electrophysiologist is this. You can see a catheter sitting in one of these veins. On ECG, electrical recording of the heart, here the patient is in normal rhythm. This is one of those P waves we talked about. But you can see that even here, this pulmonary vein starts firing these extra beats. And as a few beats get fired, the patient goes into atrial fibrillation, and you no longer see these discernible little P waves. And the time we started doing it, I really like this illustration of atrial fibrillation ablation. Smoke included. Now, smoke typically is not a feature of the procedure, as you can see here. But in order to complete this ablation procedure, we need to put catheters, thin wires with electrodes into your heart through a little intravenous in the groin. So the vein in the groin, kind of on the side of your leg, goes up to the heart. It enters the heart right here, and we'll put these little catheters through the intravenous. We typically put 3 intravenous in the groin. We do it under ultrasound guidance, trying to eliminate any risk of bleeding related to getting the intravenous in. We'll get the catheter into your heart, go from right upper chamber into the left upper chamber, and then perform the procedure. There are 2 common varieties of the procedure that we perform right now. One is called radiofrequency ablation, where essentially we put a catheter on the tissue and we deliver electrical current at radiofrequency that travels between the catheter and a big patch electrode that's typically on your back or your leg. With that, the tissues immediately in contact with the catheter heat up to as much as 70 degrees. And we create a local kind of cautery effect, a local burn. These burns eventually form to scar formation around the opening of the vein. And when that happens, electrical impulses stop conducting in and out of the vein, causing the arrhythmia. Another way of doing it is putting a balloon-tipped catheter into the vein. This balloon gets frozen with temperatures in the balloon plummeting to minus 80, minus 90 degrees. And then the temperatures of the surrounding tissues going below about -30, -40 degrees. We keep it that way for a few minutes, creating a layer of frostbite around the vein with the same effect, with the idea of forming scar tissue around the vein, and that scar tissue then preventing impulses from going in and out of the heart. There are some, again, nuances to why we would do one procedure or the other, but for all intents and purposes, they're very similar, both with respect to their safety and their efficacy. And just a little aside, this here shows a series of little burns delivered to prevent an atrial flutter. Sometimes we have to do that when patients have both an organized rhythm, a short circuit around the valve between the right upper and right lower chambers that happens to use this bit of tissue kind of as an afterthought of the procedure. We deliver a few lesions here. This blocks the short circuit of atrial flutter. The two arrhythmias are associated probably about 30-40% of the time, roughly. I'll try to take you through a video that sort of shows you what the ablation is like. Hopefully it will play. It's a relatively large video. I'm not sure 100% will play. Sometimes it may not like Zoom, but let's see. There we go. So at the beginning of the procedure, we'll put an ultrasound probe into the heart. One of those catheters is an ultrasound probe. We record images of the heart in various planes, and then by drawing contours around these images, we're able to build a whole map, kind of this big blob, a map of the heart chamber. Once we've done that, we'll put another catheter with a bunch of little tentacles with electrodes into the heart, and we start moving it around using the software, essentially sort of a augmented reality type software, in this case called Carto, but there are a number of different manufacturers that provide it. This is just happens to be the one we typically use. We move this little brush type catheter around to the left upper chamber and create anatomy for the veins and the main chamber. We'll also collect information about the tissues, how healthy or unhealthy they are. And in this case, purple is healthy. We then replace the catheter with the ablation catheter. That's a catheter you can see here. And we go and deliver these little burns or lesions around the veins. We have a number of different parameters guiding us as to how to deliver the lesion. We monitor the amount of pressure delivered at the tip of the catheter, making sure that we're not putting too much force on the tip of the catheter, but also not too little force, or else we won't be able to create a lesion. And then we deliver lesions for various amounts of time on the front and the back of the heart. Your foot pipe, the esophagus, goes right behind the heart, roughly about here. And so when we deliver lesions at the back of the pulmonary veins, at the back of the heart, we generally try to deliver less energy, and so much as possible, we try not to deliver as much force as we would on the front of the heart. And we continuously monitor all of these parameters. We'll monitor the force, we'll monitor the impedance, we'll monitor your breathing, we'll monitor the amount of force that's being delivered by the catheter, etc. Now, when we're done with all of that, the final product kind of looks like this. So this blob represents the chamber of the left atrium. These are the veins coming off the chamber, and you can see these rings or circles of lesions that have been delivered around the veins. At the end of the procedure, we go with a catheter into the vein to make sure that there's no electrical activity in the vein. We try to pace inside of the vein and make sure that there's no electrical activity coming out of the vein into the main chamber. 20 years ago, when we did our first two ablations at South Lake, these procedures took probably 3 or 4 hours at the minimum. Now, most of the procedures take about 45 minutes to an hour. Success rate of the procedure is about 75 to 80% with the first ablation. 80% of the patients, and we follow every single patient from patient number 1 in our kind of quality improvement database at the hospital. We find that 80% of the patients generally get away with one procedure, about 20% end up having a second, and that could be months or years later, and 5% may need to have a third procedure at some point down the road. We have had a handful of patients who've had to have more procedures than that. We used to keep patients overnight after the procedure. Now we typically send everybody home the same day. About 4 hours later, we let patients get up in about 2 to 3 hours after the procedure. You may hear in the news about a number of other newer emerging technologies for AF ablation, and here are just a few of the catheters that are coming to the market in the next little while. These technologies are different from both freezing and burning. They use what we call non-thermal ablation. Essentially, what happens is the system uses these multiple electrodes on the catheters to create an electrical field, a really strong electrical field that opens up pores in the walls of the heart cells. These pores allow the electrolytes to come in and out, and the cells kind of get overloaded and die without being burned or frozen. The technologies are very promising, but at this point, all of these technologies, generally speaking, are investigational. The first few will come on the market in Canada in the next few months. We participate currently and have participated in research studies looking at these technologies. And again, they're promising, but time will tell just exactly where they fit with respect to where we're at now. There are some risks to the procedure. There's a risk of bleeding at the groin, obviously. That risk has gotten a lot smaller since we've been using ultrasound to access the blood vessel. There is some risk of bleeding around the heart. Again, we mitigate it by using ultrasound, intracardiac ultrasound, 100% of the time to monitor the catheters as well as monitor the pressure at the tip of the catheters through the procedure. There's always, anytime we muck around with the heart, there's always some risk of a heart attack, stroke, risk of damage to the vein, causing it to narrow, risk to the foot pipe or the esophagus in the back of your heart, and injury to the nerve to the diaphragm, as well as risk to life. But generally speaking, all of those risks add up to less than 1%, with a risk of death of less than 1 in 1,000, making it a relatively safe procedure. And currently, we do about 20 of these procedures, give or take, in a week, having been able to shorten our wait list for the procedure to about 2 to 3 months at present. At this point, we're open for any patient with symptomatic atrial fibrillation or patients who may not be aware of atrial fibrillation but have congestive heart failure. Studies have shown that these patients may derive survival benefit with ablation. Survival in patients who are ablated like this is actually better than in patients who are treated medically. Some patients may have a combination of atrial fibrillation and a really weak electrical system in their heart, where they have atrial fibrillation, and whenever it stops, it takes a few seconds for the conduction system to take over. We call those pauses conversion pauses from atrial fibrillation to normal rhythm. In those patients, if we're able to eliminate atrial fibrillation, we can eliminate the pauses without the need to put in a pacemaker. So these patients are also kind of a one group that really gets helped with ablation. Patients with defibrillators may get shocks for their own reason if the defibrillator decides that the patient is having atrial fibrillation rather than a more dangerous arrhythmia from the bottom chambers of the heart. Those patients come in for ablation in order to eliminate atrial fibrillation, take it out of the equation, and help further prevent these kind of events. Typically, we offer ablation to patients under 85 and those with left atrium that's reasonably sized, under 65 millimeters, although we have made exceptions to specific patients. The patients also need to be able to tolerate a blood thinner. We need to make sure that the patient can take a blood thinner for maybe a couple of weeks to a month before the procedure and at least 2 months after the procedure. Because we create damage on the inside of the heart, and we don't want the patient to form a blood clot. So if you cannot take a blood thinner, you really at this point cannot have the procedure done. And there's relatively little evidence to say that ablation itself prevents stroke. So at this point, if you have an indication for a blood thinner before ablation, you typically still have that indication after ablation. But we're continuing to accumulate evidence. This is our team of electrophysiologists. Myself, Dr. Tseng, Dr. Wolfhard, Dr. Sadak, and Dr. Pantano. Myself and these two doctors currently perform AF ablation at Southlake and see patients at pace. But you may have met all 5 of us through your patient journey. You also meet a number of nurse practitioners. In order to shorten our wait list, we spend a lot more time ablating the arrhythmia and perhaps not enough time seeing patients in the clinic. And so a number of visits are now with nurse practitioners who we've trained, and they're really quite excellent and helping you along. Some of our nurse practitioners see patients before the procedure, Katrina, Anastasia, and Blythe, and pre-assess you for the procedure, as well as they may see you after the procedure if you have any urgent issues right after the ablation. And then we have other nurse practitioners, Jill, Irina, Sherry, Sue, Dev, and Puneet, who would see you in your follow-up. And we typically bring you in for follow-up about every 3 months for the first year before sending you back to see your referring physician, referring cardiologist. You have also been in touch with Tiffany, our triage coordinator for AF ablation. She's the one who actually books the procedures. And Mona, she is the arrhythmia RN, who calls you up 2 weeks after the procedure to make sure you're okay. And again, in the first 3 months, if you have any problems, we want you to call Mona and let her know. She then takes these messages to us. That's really all I wanted to say. I once again wanted to pop up the QR code that will take you to a little website we put together with patient resources, including a little patient handbook for our atrial fibrillation patients. And I've also mentioned through the talk, I mentioned our partners. Pace Cardiology is a clinic that I work at. That's where we see our patients before and after their ablations. My view is the wellness outfit that we use to help our patients was a lifestyle management and lifestyle modification. And Myant is a company where we get the monitors. Now, we use these monitors as Holters in the clinic, but there may be a value for you to have one of these monitors permanently as your own monitor. You can purchase it on the Myant site, and this code will associate you with our group and our clinic, where we will be able to follow your ECG and other health parameters over time should you choose to get your own monitor. So thank you very much. Thank you to our partners and to my hosts who were fielding the questions while I was chatting. And hopefully we'll see all of you in March or sooner. Bye for now.